First of all, I'm very happy to be here, and I would like to welcome all to this session. We are not so numerous today, but maybe tomorrow. So I'm definitively not an AI girl. I'm just a nephrologist and medical director of the Paris Institute for Transplantation and Organ Regeneration. And my clear role is to transfer the developments we make in research to clinical practice, clinical trials, and patients. And today I will be very, very concrete. So definitively we all need AI today in transplantation because we have to deal with so many things, with so many data for each of our patients, from clinics to biology, histology, and these are connected with hundreds and millions of data coming from other patients. And by the end of the day, we need this AI and the AI algorithms that can help us to contextualize the patients in the universe of transplantation. Because in this system, any patient can enter and inform the system, and every patient will be informed by the systems in terms of diagnosis, treatment, and clinical outcome. And we cannot imagine today the future of transplantation without innovation. And innovation is still today with immunology, digital pathology, molecular microscope, etc. And all these technologies need AI. So definitively AI is here, the revolution has started, and AI is already reshaping the landscape of transplantation medicine. So I promised you to be very, very concrete, and today I will bring here how prediction systems we have developed are used clearly today in a real world, in a real life, to improve the follow-up of our patients. So the starting point was the development of iBox. iBox is a prediction system for risk of allograft loss in patients receiving kidney transplantation, and it was developed on hundreds of parameters coming from donor, recipient, HLA, etc., etc. But the most important thing to develop such robust tool is to have a very wide development of the cohort and of transplant phenotype patients. So this iBox today is validated and included more than 30,000 of patients from 5 continents and 49 centers. And by the end, the final model is easy to understand for the clinician. It's something that we use every day in our practice, time for transplant, functional parameters like EGFR proteinuria, scores of scarcity from histology, markers of hemolytic, and presence of anti-HLA donor-specific antibodies. The system is very performant, is very stable in different clinical scenarios and subpopulation in stable, unstable patients after 1 year, before 1 year, with induction, no, without induction, in hypersensitized patients, in general population, etc., etc. But it represents a prediction system at one time moment. This was the starting point of the iBox. But overall, the system has been completed from the seminal paper in 2019. So here you have the roadmap of the iBox with the development of the dynamic iBox. the fact that the iBox was validated in all the clinical trials performed over the last years in the field of organ transplantation. And also the robustness of the iBox was tested compared with machine learning, clinicians, fine grained, etc. And we showed generalizability, specificity, causality, accuracy, feasibility, transportability, and by the end, this iBox was qualified by EMA as secondary endpoint for clinical trials and is considered for qualification plan by FDA as co-primary endpoint. But I said I'm a clinician, and I have to understand the clinical utility of the iBox. Okay, it's a very fancy tool, it predicts well, but does it predict better than me? Does it predict better than you clinicians who know your patients, their history, their families, etc., and their environment? So the answer comes from science, and science is clinical trial. So we performed this clinical trial in which we compare the prediction performed by the machine, the iBox, and by physicians, 9 physicians, 3 professors, 3 seniors, 3 fellows. And by the end, I will not say that the machine was better than the human. I will just say that humans are very, very different, and as you can see, their predictions are also so different. So we need standardization and automatization in the prediction of our system. But all this I talked about is at one time point. But everyone knows that for the follow-up of a transplant patient, we need hundreds of measurements of the function. It's true for kidney, but also it's true for the other solid organs. And now, in my mind, it looks like this, in gray. Trajectories, I can't say something of very generalizable. And it's only the AI that can help me to transform this gray zone in trajectories for my patients. And that was done, and that we have done, developing trajectories of GFR rate and progression to renal stage disease after kidney transplantation. And again, it was robust. 15 transplant centers, 7 RCTs, more than 400 GFR measurements, etc., for define a universal 8 validated GFR trajectories for the outcome of kidney transplant recipients, and also the clinical, immunological, and histological determinants. So here you have the validation. And for me, for the clinicians, it's very easy to use it. You have the final model with the personalized prediction of GFR in a clinical application for each of our patients. And for each of our patients, we can say it is on the first class or on the 6th class, such in this example. And the follow-up will not be the same for these different patients. And I move forward and combine the first evaluation at 1 year. That gives me the first score of prediction that is quite good at the time point. And I can add hundreds of follow-up that will be able to refine my prediction of outcome for my patient at an individual level. So here you have the clinical application of the dynamic prediction of graft survival for each patient. So we have started by identifying graft survival prognostic factors. We have dynamic trajectories. Now we have to have a multidimensional system. And to do that, we need a support, a software. And the software to integrate all these AI algorithms is also an AI-driven platform for continuous care in kidney transplantation. The name I use is Predigraft. It was imagined like a clinical decision support tool for healthcare professionals to improve kidney transplant patients' follow-up, basically based on 3 pillars: the dynamic iBox evaluation every time, interoperability, and alerting system. But again, I said I am a physician, and this fancy tool, is it necessary and is it useful for the follow-up of my patients? The answer comes from the clinical study. And we performed the first randomized clinical trial testing an AI-based digital tool in organ transplantation, with the primary objective was to show that we have, using the alarm system, we can improve the changes in the treatment. So here you have the study design, standard of care, according to the center policy, and the second is AI driven follow-up, and as you can see, more than 500 patients have been included, 16 centers, 6 countries, and I can make the announcement that the primary endpoint has been reached, and the biopsies leading to therapeutic changes were higher, in a higher rate in the AI group. So clearly, we are moving in our system of follow-up of patients from an office-based care to continuous home care, and AI is here for helping us. And AI is here for making progress every day. It's not the final model, it's just, again, the beginning of a long history, because we can include in the system many other markers, for example, biomarkers. And one of them, you know, is the cell-free DNA. We have developed, again, a very strong and robust model for prediction of allograft rejection. And today, it looks like this to monitor patients with AI and biomarker integrated. We can use it all patient care journey for non-invasive monitoring, risk stratification, precision diagnosis, and therapeutics. And I will give you a very concrete example after, just to make the announcement that this is a second AI care trial in which we use AI in clinical study. Definitively, AI needs science. The AI tools need to be validated by randomized clinical trials, and in transplantation, I'm very proud to show you that we have the 2 first clinical trials using AI. So how it works in my center to do that is, it looks like this. The history, a very simple one. You have all these kind of patients in your units. 1 year evolution, excellent. The biopsy at 1 year, nothing, no proteinuria, but 5-10 years after, a slightly increase of creatinine, but we were very happy with this value of creatinine. The DSA developed are very low, and the immunosuppression was stable. But we had received the alarm of the AI system showing that, don't forget, you have an alarm, and your patient has a probability to improve the risk of graft loss. So we perform cell-free DNA, we evaluate with AI integrated, and the system has said that we have a high risk of rejection, so we made the biopsy, and the biopsy showed chronic active ABMR. Should I treat this patient 5-10 years after the transplantation? Should I not treat it? Again, AI might help me, and by projecting the patient in the universe of patients with chronic antibody-mediated rejection in order to define the activity and the response to treatment and the type of treatment. And here you have the demonstration that this patient might respond to standard of care. So we treated the patient with plasma exchange IVIG, and 3 months after, the evolution was very nice, and again, the AI evaluation after the treatment was good. So what we had in red before became green, meaning that we were able to improve the prediction of graft survival for our patients. So definitively, the algorithms will not replace the doctor. However, we need them to work and to improve the follow-up of our patients. And I just will finish by making the announcement of launching the first AI transplant clinic unit in Paris in 2026. Each patient who enters in this AI transplant clinic will have a very personalized digital twin based on all the clinical history, immunology, histology, etc. And by the end, we want to develop a personalized follow-up for each of our patients using AI. So thank you for your attention, and I hope in the next year we will be more and more here to talk about AI, and in India, I think, is the well place, and thank you.